Now we're going to open it up for questions, and we have three panelists. I'm wondering, by way of process, if we want to invite Dr. Drachenberg and Dr. Gingrich and also Robert up here. So the question is about how many research studies and clinical trials have focused on clear cell carcinoma as opposed to papillary or other subtypes, and is there going to be an opportunity for more research to focus in on papillary and other things? So it's a good question.
Yeah, it's a very good question. So as I mentioned, the study that looked at temsirolimus did include patients that had non-clear cell subtype, and that represented about 20% of the population. So based on that, that would be one drug that we will sometimes use in that situation. There are smaller studies that have looked at non-clear cell type and showed that some of the drugs like sunitinib do have some activity in them. There is a study that's ongoing right now that's comparing to see in non-clear cell subtypes which is the best treatment. So they're comparing some of these common ones like sunitinib with everolimus, for instance, to see which one is going to be the best one in that situation. So yes, there is studies that are ongoing.
It's actually a topic that comes up on our kidney cancer discussion forums, pardon me. And I don't know if you're online, but that question has come up, and many of us have had non-clear cell types, myself included, so it's certainly one that I pay attention to as well, because certainly more attention needs to be given in that area. Yeah. Any other questions? Repeat the question and then respond? Sure. Thanks.
So Tony asked that why does it seem that men get kidney cancer more commonly than women, and certainly that's the statistic currently. We're not exactly sure what that is. We don't know if it's a genetic thing. Is it something related to testosterone? We don't think so. But it's probably related to environmental factors. So smoking history, with more men in the past smoking than women, and now smoking from a younger age, and then they become middle-aged or older with all that smoking history, probably is some kind of impactful factor. Maybe some other environmental exposures potentially, and people in the mining industry and people in other kind of higher risk industries potentially, which have been predominantly male. But we're seeing that, much like with bladder cancer, we're seeing a little bit of a change now in the incidence, with females doing a lot of the smoking now from a younger age for weight loss and things like that. The incidence rates are increasing, unfortunately, in that population. So we don't know exactly what it is, but it's probably a multifactorial thing. So the question is there any test, a screening test available potentially to find kidney cancer in patients that are asymptomatic and present without bleeding or pain or other kind of symptoms other than imaging? And the short answer is no, there isn't at this point. Unlike other cancers like prostate, for instance, there's a tumor marker that we would kind of advocate ordering on patients that are at risk to see if they have the risk of prostate cancer, and then we would set along the pathway of diagnosing it based on that tumor marker that's shed in the bloodstream. So it's a simple blood test. We don't have anything like that currently for kidney cancer. Down the road, there might be more of those tests available, but at this point we don't really have anything that's ready for prime time. There's things like circulating tumor cells that people are looking at and things like that, but at this point we don't really have anything other than if a patient presents with symptoms, like for instance your case, blood in the urine, well then they need to be seen by a urologist. They need to have a workup to rule out cancers either of the bladder or of the kidney. If they have pain, then they get an imaging study, they find it that way, that kind of thing. But generally, for the well patient with no symptoms, there's really nothing other than imaging that can detect it, and in those patients we don't get annual imaging. Maybe down the road at some point we might consider things as imaging costs come down and radiation from imaging gets better. We might consider doing imaging at a certain age to try and find these incidental things, but at this point we don't.
So we have a question for Dr. Gingrich. When do you expect the sunitinib intolerance restriction on Voltaren to be lifted in Manitoba? I know who asked this question. We're an advocacy group, right?
Yeah, I mean, it's a good question, and I think with this recent publication that's come out now in a very prominent journal saying that pazopanib has similar efficacy to sunitinib but has improved quality of life in a number of different quality of life questionnaires, that it's going to put increased pressure for that. So I don't know exactly when it will change, but I think Kidney Cancer Canada and patients in general, the more that we can advocate for drugs for patients with advanced kidney cancer, the better. So I think the louder and more noise we can make, the faster things like this are going to change.
So the question is about kidney function and
Kidney function
yeah,
and how
so
cancer would affect it.
yeah.
Yeah, so first thing, congratulations on that 5-year endpoint where we say you're disease-free and cured, which is great, and that's wonderful. Yeah, so we know when we remove a kidney, and that's why the nidus towards trying to preserve the kidney as much as possible, even in patients that have larger tumors, is very important. When you remove a kidney, you have what is left with 50% renal function, essentially. And in someone who's healthy without comorbidities or other things like diabetes, high blood pressure, etc., people tend to do okay with one kidney. About 1 in 400 people in society doesn't even know it, but they're walking around with one kidney. They're born with one kidney. So often we don't know about that until sometime down the road we find out that they have one kidney. But so some patients, though, are unlucky where they have some other issues with the kidney function and their one kidney is removed and they're working already with 50% restriction, and then you can get a steady decline of that kidney function. That doesn't put you at any higher risk of getting cancer in that kidney, the fact that the function's decreasing, but it certainly puts you at risk for developing the need for dialysis or going on to kidney replacement therapy with dialysis. So certainly at that point, when you had your kidney removed, you probably should have been seen by a nephrology doctor who specializes in kidney diseases, and then optimizing your kidney function as much as possible, trying to treat anything that might cause problems. So if there was high blood pressure use, treat those things to keep it controlled. If there was high cholesterol issues, treat that. If there was smoking history, stop smoking. If there was other chronic kidney issues that could be found, medical treatment, sometimes some antihypertensives are bad for the kidney and cause bad kidney function. So certainly anything to optimize the kidney function should have been done at that point. And sometimes it's unfortunate, but you can't stop the inevitable decline in some patients over time with kidney function. And the goal would be to preserve as much function as possible for as long as possible. And with 16% function at this point, you're not on dialysis at this point, but it might be, if you live long enough, possibility down the road. So a good nephrology doctor should certainly be watching you quite closely. Oh, good, good.
Actually, we have another question for you, Dr. Drachenberg. So it says chest x-rays use pre-surgical workup and for surveillance rather than chest CT if 60% of renal cell carcinoma mets are found in, in the lungs.
So why is chest x-ray?
Yeah, so chest x-ray is used because we're trying to balance the ability to diagnose a spread of cancer to the lungs, but we're also trying to balance when you get a CT chest, we find all kinds of little nodules, like Robert would attest to, that can get patients really, really worried when his went away spontaneously. So it's something about living in our environment with the pollution we breathe in. Almost everybody, if they live in this environment long enough, will have nodules in their lungs that are small, inflammatory or non-inflammatory, granulomatous scarring. And CT can make people get really worried that they have cancer there. And so we might actually overstage them and say that they have metastatic disease. So chest x-ray is a good balance because it doesn't pick up those really, really small lesions that we don't think need to be picked up. And also a chest x-ray is less radiation than a CT scan, and radiation in itself can risk having cancer down the road. So we want to minimize the radiation to patients. We want to maximize the diagnosis of cancer in the chest, but we also want to minimize the false positives of these small nodules that we see. And so we don't routinely do a CT chest for staging, and we use chest x-ray in that regard. If there is something on the chest x-ray, we always will follow that up with a CT chest to be more exact.
All right, so the question was, at what point did I decide to tell my children, my 2 boys, about my disease? And the answer is, we haven't really told them yet. They're 7 and 8 years old, and I don't want to increase their anxiety level about what's happening with their dad. I mean, they know that I went to the hospital. I still brought home some of my surgery stockings and stuff like that, and we played with them, and we had a good time. Dad went to the hospital because he had a bellyache, but he's okay now, and that's kind of how it went. So, I'm not like a psychologist. I don't know when would be a good time to break it to them. And at some point they're going to know. But right now, as young as they are, we're still kind of keeping a lid on it. Because I think, kids are really aware these days. They hear the word cancer and it probably sends off alarm bells. And I don't want them, having any undue stress because of that. So we haven't told them yet. They haven't found out either, so that's good.
I can share my experience. I had kidney cancer when my little guy was a year old. And so he's 8 now too, but he does know. I have this massive scar, and he thought that's where the baby came out. So we haven't had that conversation though. But he knows that I had kidney cancer, and I've spent a lot of my life over the last 8 years volunteering for an organization. It's been a really positive experience, and we have conversation about it. And he hears cancer, he thinks of Terry Fox, and that's of course a big part of what happens this time of year in schools. And so lots of people have cancer, and I happen to know about mine. And so that's kind of how I've lived my life, and it's not about anxiety and having him be afraid of that, but I think every parent knows their child and knows what's best and how to have conversations about things that are difficult, and it worked out just fine for us.
And can I just interject there? So I agree 100% with how you handled that with your son and how he's handling it with his children. I would say, though, that apart from the whole psychosocial aspect of telling a child they have cancer, that it's very important that when they come of age where they're going to be seeing their doctors by themselves, they need to tell their family histories. And in your case, both of you, because you had kidney cancer at a very young age, they need to tell their family doctors, my dad had kidney cancer and he was in his 40s. My mom had kidney cancer, she was in her 30s. And that imparts a significant risk to them, especially early on in their life if their parents had cancer at an early age. And they need to know about that history to tell their doctors to be suspicious. If they get a urine test back which has some blood in it, we'll take that seriously even if they're only 30 years old, because might have been able to find your cancer much earlier. Yeah.
Can you talk about what you might suggest to a parent who had kidney cancer and surveillance, or at which point with your child, particularly in a rare subtype where there might be a question of
hereditary syndrome?
We've had this conversation.
Yeah, exactly. So it's difficult because you first have to suspect potentially a hereditary syndrome that it may exist, and you kind of need to know which pathologies belong to that hereditary syndrome to consider which other manifestations can exist in the patient. But certainly, I would tell the patient that their children, when they get into their 20s and certainly in their 30s, probably should have that talk with their family doctor and should probably have an ultrasound of their kidneys just to make sure the kidneys look normal and that they don't have any small tumors beginning in that age group. If there's hereditary cancer issues, like I said, they usually start seeing cysts in the 20s and tumors in their 30s. And we can usually catch that on imaging at that point, and then we could watch them proactively with the surveillance until they get to a size that would need treatment. Now, not every child of someone who's afflicted with these hereditary syndromes gets kidney cancer, but if we know that the patient belongs to a family of kidney cancers, they should probably see a medical geneticist and get the genetic testing, because that way we'd know 100% their risk. If they have the gene, then they have a risk of getting it. If they don't have the gene, they have no risk of getting it. They have no risk of passing it on to their children, and it would be important for them to know that information. So if we have a documented hereditary syndrome that I suspect, and we get a mutation positivity back on the patient, all their children should have that test, and 50% of them will be randomly afflicted with it, and those 50% should be followed very closely. The other 50% should know about it, but they're not going to get kidney cancer, and they don't need to worry about that surveillance or even having that talk with their doctor.
There's a question.
So the question was about at what point do we start getting concerned about the growth of these things, because at small sizes the growth is very slow and it takes years to get to the point where it's a significant tumor. So the data is pretty clear now. The data came from the hereditary cancer syndromes where we know the diagnosis, and we also find tumors very small and let them grow for a while. So 3 centimeters to 4 centimeters seems to be a cut point as to where the risk of having kidney cancer mutations that would allow spread elsewhere occurs. Anything less than that size has a very low risk, and in that case we probably can safely watch patients for a number of years before those tumors would grow to a size to be needing treatment, and often may never even grow to that, especially if they're benign. There's about a 20 to 30% chance that tumors less than 3 centimeters aren't even cancer, even though the radiologists would call them cancer. They're not cancer, and so those ones may never grow. And so we can avoid treating those people that have no growth rate and only treat those ones that have growth rate after they get to a certain size, like we use a cut point of 3 centimeters.
So let me just paraphrase what your question was for everyone if they couldn't hear it. You were mentioning that you've been on sunitinib for about 1.5 years, and initially you had quite a bit of side effects from it, and you said it nearly ended your life because of those side effects. And since then the dose has been reduced and you're doing better with it now. And so far the tests have shown that it's working. And your question was, well, what does this mean for the future, and is it going to continue to work in the future? Is that right? Yeah, so a question, let me answer that by put it into two parts. One part is that there, I think, is good evidence that if you take a lower dose of the medicine because of side effects, it doesn't mean that the medicine is going to be less effective. It means that your body is essentially telling you and telling us that you don't need quite as much of it in your system to do the same job as the next person. And we usually start off with just a standard dose that's somewhat arbitrary based on a great group of patients. And so some patients are going to require a little bit higher dose, some are going to require a little bit of a lower dose. And the side effects are one way of showing us where that level might be for you. So patients that are on a lower dose can still do very well with it. Patients that are on it for a while, where their side effects are fairly stable, most of the time it continues to be like that. Some patients will notice when they've been on it for a while that the side effects do slowly over time build up. And so sometimes it requires changing the schedule or changing the dose of the medication or even taking a bit of a break from it. Or sometimes we will think about switching to a different drug like pazopanib, for instance. I think the last part of your question, if I heard that right, is will this drug continue to work for a long time? Was that part of it?
A long time has become a relative thing.
Yes. So we have some patients that have been on these medications since they first came out. And they've been out for 5 or 7 years. So there's some patients that can be on it for a long period of time. Most patients, if you look at the average, as we said from the clinical trial, are on it for about 11 months before it shows evidence that it starts to lose its effectiveness. So how an individual person will do depends on that individual. And the fact that you're doing well now is very good, and hopefully that'll continue for a long time. And if or when it loses its effectiveness, there are other drugs that are available that can still be effective.
So the question is high-dose vitamin D good for kidney cancer? And especially in your case when you're preparing to see a surgeon about having a kidney surgery potentially. So there had been some thought about the ability of vitamin D to be preventative for cancer and also possibly a treatment for some cancers. Looking at some epidemiologic data where they looked back at patients or people who were on vitamin D and then looked at their incidence of developing cancer. So that was a signal that people looked at from those studies saying, well, maybe this works. But then when they actually looked at it in clinical trials, they found that it didn't really work. As a matter of fact, it was probably not helpful and harmful potentially sometimes in people. So that's fallen along the wayside and we don't recommend it. And in your case, especially if you're considering having some kind of kidney surgery, the kidney stone issue I think could be a real thing. So we wouldn't want to have a kidney stone either make you too sick to have surgery or cause your kidney to not function or things like that. So I would say, the recommended daily allowance of vitamin D is great, but I wouldn't go any further than that.
What would be the recommended amount?
Well, it's variable. So we recommend, for patients with prostate cancer, we recommend about 1 gram to 1,500 milligrams of elemental calcium a day, and we recommend somewhere between 1,000 and 2,000 international units of vitamin D. It's kind of a moving target, but in our climate with long winter days that have no sunlight and things like that, we think that pretty much everybody is vitamin D deficient in our population, and so most people should be on supplementation, but not above the normal kind of recommended daily allowance of that. And we're pushing that daily allowance in our population in Canada because of where we live and the ambient light that we have. People live in southern U.S. and in tropical climates don't need anywhere near that or may not even require it at all. But we think that there's probably some sweet spot somewhere between 1,000 and 2,000 international units, I suspect. And I would take calcium along with that if you're taking the vitamin D, or else the vitamin D doesn't really help. So the question is about if all the cancer is surgically removable in a patient who has lymph node spread, if there's any further treatments that are needed. And generally we know that when they call that adjuvant treatment, so that's after surgical removal of all disease. If there's still a risk of some cells being around, sometimes we would give for certain cancers like breast and colon, and Joel knows this more than I do, some chemotherapies or other treatments that might be used afterwards to prevent the risk of getting more cancer down the road if you're at high risk. For kidney cancer, the data is not available at this point for that, so we don't think that adjuvant therapy at this point can be recommended. But that's something that's emerging. There was over 1,000 patients in an adjuvant trial that we were involved in at Cancer Care Manitoba that's now coming out with some data probably within the next year to 2 years that might show benefits. We might consider for certain patients with high risk, we might put them on some therapy. But if complete surgical removal is done, nothing other than just follow-up surveillance with close observation, looking for more cancer is needed. Mm-hmm.
We were sent to cancer care and we saw Dr. Gingrich, and why would that have been then at all?
Why were you sent to cancer care?
Yeah.
Well, so if the cancer did recur, once you kind of in the system so that you're seeing the appropriate people, then you get the appropriate therapy. So, often, the cancer care doctors have a little more ability for managing with resources those kind of patients that are at higher risk. And so, sometimes we, in a multidisciplinary fashion, so the surgeons, the medical oncology doctors, et cetera, will see patients in common and will make decisions based on that. Some patients, rarely will get some of these treatments before surgery, and then we'll treat them afterwards. So we like to have a lot of communication between the two groups in regards to these kind of complex cases. And so probably in this case, the referral was made because there was demonstrable significant lymph node disease. So the lymph nodes weren't just truly incidental small lymph nodes, they were quite large. And in that case, the risk is potentially high of recurrence. We want you to be found early and treated early if possible. So we like both camps and both the hands in both camps at that point. And that's why I think we probably did that, just because of the perceived risk was greater and the fact that we want you seen by the people who could treat you if you did have a recurrence.
Thank you to everybody this evening for coming and for your questions.